Thank you, Prof. So some of you would have looked at the program and you'll see that my topic says the burden of obesity. But this is a title of a talk I had given in 2002. And I want to show you that already at that time, I thought we had lost the battle with obesity. And so is the screen sharing, guys?
Yes, it is.
Yeah. So I'm going to quickly just go through this, but there's a slide looking at North America, 1985, looking at obesity. And if you look at the percentages on the bottom, it's color coded. And I'm just going to go through it over a 15-year period. And you can see why at that time I thought we had already lost the battle. Because if you look at it, over half of this graph had a BMI above 31. At the time, this was the only South African paper at the time looking at obesity. I want you to cast your eye towards the last four columns. And if you look in our African population, at the time, our females had obesity rate, BMI above 30, of around 30%. And 28%, Asians 20%, and then the white population 25%. So already at that time, we were sitting with a burden of disease that we were not even dealing with. Because remember, at that time, obesity was just considered a cosmetic issue. Our men were much better, and the ranges were anything from 7 to 20. And here you could see from a race group perspective, the data was actually reversed. So let's come to present day, and let's look at the burden of disease. Now, if you look at this particular graph, looking at from 1996 to 2016, South Africa is about the 10th country. If you look at the prevalence, we're looking at anything between 15 and 20 over a period of time that starts increasing. And now 2016, which was 5-6 years ago, already about 30% of the population sitting with obesity. We're sitting with a pandemic, 650 million people worldwide living with obesity, of which around 40% have been diagnosed and less than 20% have had any form of treatment. So we're really sitting with an issue. For the first time, a few years ago, there are more obese people on this planet than malnourished people from an underweight perspective. In terms of South African data, or more recent data, the best data comes from the Discovery Health Vitality Group. And then I'm about to publish our data from Gauteng, where we screened over 5,000 people. And we're looking at about 70% of our female population either overweight or obese, and 31% of male patients sitting with obesity. Now, that's not the worrying data. The worrying data is that 13% of our children are overweight. And if you look at worldwide stats, it's around 6%. And there's work showing that if you're an obese child, the risk of you being an obese adult is extremely high. What is one of the problems? Well, our patients who are overweight believe it's their responsibility to manage the weight. And we as practitioners never confront our patients because we think they're not interested in losing weight. So this label that we as practitioners lay on our patients is one of the biggest barriers to treatment. And so we are happy to treat the underlying conditions that are related to obesity in terms of hypertension, diabetes, coronary artery disease, but we're not looking at the elephant in the room. And so we think that our patients are not interested in losing weight, and that's the perception 71% of us have. And only 7% of the patients that are obese are actually not interested in losing weight. 93% of them want to do something about their weight. And so the gap between the patients and us having a nexus, a talk about weight loss, is about 6 years. And in that time, the patient has failed at least 4 attempts. And most of that is then going to lead to just patient losing motivation and drive in terms of losing weight. And so this was supposed to be blanked out, sorry. And so again, just showing that only 3.4% of patients with a BMI above 40 are actually being prescribed something, and yet that something is available. A few years ago, I did a talk on a paradigm shift we need to have in terms of obesity. And the reason for that is that it's gone away from that scale that we used to look at, where we say input equals output, and that's the cause of obesity. This is the mind map in terms of energy balance. And our brains are conspiring for us to hold on to weight as much as possible. And the reason for that is, for most of mankind's life, food has been a scarcity. And so from an evolutionary perspective, there are many, many pathways that are all conspiring for us to hold on to as much weight as possible. So this hyperinsulinemia, high cortisol levels, these were all protective pathways over millions of years of evolution to allow us to hold on to and store energy. And in the last 100 years, that's come back and to bite us. And so, of course, obesity is going to be a problem. But this shows at the hypothalamic level, there are many pathways that are all conspiring towards working on satiety and on hunger to get us to store the calories. One of the burdens we're going to be facing is that there's already over 250 loci that has been shown to be associated with the obesity trait. Now, there are numerous factors besides just what's going into our mouths that's contributing towards obesity. And that adds to the burden of how we're going to be managing these patients. So there's genetic predispositions, there's a whole lot of environmental factors, important one being endocrine disruptors. There's a whole lot of hormones that we know of that all conspire in terms of weight. And then I just got the tail end of Prof. Raoul's question in terms of some of the endocrinopathies that can be involved. But remember, not all of this world's problems lie with the thyroid gland. And then if you look just in the northern suburbs in Johannesburg, about 50 to 60% of patients are on some kind of a psychotropic drug. All of this, except for Wellbutrin and Topomex, anything a neurologist pens or a psychiatrist pens is going to contribute towards weight. So that becomes a problem. But I believe one of the biggest issues we're going to be facing as practitioners in terms of battling along with our patients in terms of weight reduction is this issue of set point. We are all born with a particular set point, and that is set around the age of 16 to 18 and gets well established. And that's the weight the body is going to defend. And then due to environmental factors, hormonal factors, eating problems, drugs, all the factors I've just mentioned on the last slide, as weight goes up, if that weight sits at a higher set point for a while, the hypothalamus then resets and tries and protects that particular set point. And so the issue is, unless we're going to have a multidisciplinary approach in working together to try and get that weight down, we're going to be sitting with a problem with our patients. And so there's medical and surgical issues which are going to be dealt with today in terms of managing this. For my talk, we're just talking about the burden. This slide looks at what happens when a patient tries and loses weight, the metabolic adaptation that the body is going to try and reset that weight. And that is why no matter what we do, there's lots of ways patients can lose weight. They've tried different diets, they've tried different exercise programs, they tried to eat less from a caloric perspective. There's lots of medications that came and went on the market from the 1970s. Most of them have been withdrawn because of cardiovascular issues. They all lose weight, you can see. But over a period of time, that weight comes back. And so this is an issue. So a lot of the drugs available on the market are quite costly. And we mustn't look at how much it's going to cost us from a dietetics perspective, exercise perspective, our work on trying to improve legislation to have an impact on what goes into the calories we eat. This is a catastrophic economic burden on a lot of the economies. And one way or the other, weight influences every one of us. So when a diabetologist or a general practitioner or an endocrinologist is trying to work on diabetes, just remember the precursor to this is central obesity. Our gastroenterologists are going to be overburdened with NAFLD and NASH, and then of course, as a consequence there to cirrhosis, all come back to obesity. Our cardiologists and neurologists and nephrologists look at cardiac failure, myocardial infarction, stroke, CKD, all stems back to obesity. And then whether it's osteoarthritis, whether it's obstructive sleep apnea, whether it's fertility, cancer, all of those in one way or the other through intricate pathways, the burden of the disease that we currently dealing with from a cardiometabolic perspective and cancer perspective all stem from obesity. There's over 229 different complications related to obesity, and it spans across every subspecialty. So the burden of diseases, chronic diseases that you and I manage on a daily basis, the primordial issue to all of those, one way or the other, either from a cause or from a contribution perspective, comes back to obesity. But the main reason why we should be paying attention to this, and that it's no longer a cosmetic problem. In fact, it wasn't a cosmetic problem back in 2002, where we already lost the battle, is that BMI has an impact on mortality. So a patient with a normal BMI reaching the age of 70, there's an 80% chance of that happening. However, if the patient has a BMI of 35 to 40, they only have a 60% chance of getting to the age of 70. And God forbid, if you've got a BMI between 40 and 50, you only have a 50% chance of reaching 70. Now, the issue is this, that this is graphically showing what your chances are of getting to the ripe old age of 70. The problem is this BMI is recorded in the 50s. So most of us by 70 only have about another 12 good years left. And so if you're cutting away 50% of that time, that's having a major impact on mortality. I heard Fernanda touching on this. The biggest issue, the biggest obstacle and burden we face in managing obesity is that we as healthcare practitioners, we as a society discriminate against patients with obesity. That's been well studied as well. If you look, the second top cartoon, we are not taught about obesity. So even in our curriculum, we're not teaching obesity, we're not looking at the causes of obesity, and we're not teaching our young doctors how to manage it. Because if you think the burden of managing obesity lies on endocrinologists, guess what? There's only about 60 of us, of which 20 have retired. The other 40 are distributed between private practice and government practice. And so there's no way we're going to be able to treat the 2.5 to 4 million odd people living with just being overweight. Lots of drugs on the market that can contribute towards obesity. There's no subspecialty that has claimed management of obesity. And then the ones who are treating it don't know how to get reimbursed. And we don't know how to get the drugs reimbursed. So we've got lots of uphill battles with the funders and with government. And there's definitely insufficient obesity quality of care standards put out there. So lots of challenges. There's a burden that we all face in terms of, number one, diagnosing obesity. Number two, what we need to do with it. And number three, how are we going to get government and funders to be backing all of this? I'm going to leave you with this thought. If you look at the number of deaths from TB, HIV, malaria, and road deaths, they pale in comparison to the number of deaths from diabetes. And 85% of patients with type 2 diabetes have type 2 diabetes because of obesity. This is one of my starting slides in 2006. And we spoke about the shape of things to come. I think we're already there now. And so we all have this burden of a condition called obesity, and we all better shape up in terms of managing it. Otherwise, we're throwing good money at the end to managing heart attacks, which is a revolving door, strokes, which is too late, chronic kidney disease, which cost the US government trillions in terms of managing, and we don't even have enough dialysis slots. So let's try and prevent this condition. So I'll leave it there.
Thank you, Sindeep. Appreciate the talk and